Welcome back to the Masterclass, everyone. Harshal here. Before we jump into today's explainer, a quick reminder, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. All right, today we're tackling a seriously high-stakes area of healthcare administration, inpatient coding. If you've ever wondered how a provider's clinical notes actually translate into hospital revenue and quality metrics, well, you are in exactly the right place. We're going to decode the often complex relationship between what's written in the chart and what the hospital actually gets paid. Because in the inpatient world, precise clinical documentation literally determines financial survival. Let's get right into it. To really grasp why this matters, picture this. A patient is admitted with chest pain and a history of diabetes. If the discharge summary just says chest pain and doesn't link it to the underlying cause, man, that is a prime example of poor documentation. The hospital is going to get a much lower payment and probably face some compliance risks too. But look at the flip side. What if the note says acute anterior wall MI managed with PCI and linked to type 2 diabetes mellitus? That is exactly what we want to see. It's specific, it's well documented, and it perfectly reflects the intensive care the team actually provided, ensuring the facility is fully reimbursed for the heavy resources they used. So, you're probably wondering, how does that payment actually get calculated? It all revolves around the IPDRG. That stands for Medicare Severity Diagnosis Related Group. You can think of this as a giant statistical sorting hat. It takes every single inpatient stay and classifies it into a group that shares similar clinical characteristics and consumes roughly the same amount of hospital resources. This system is absolutely huge. It forms the total foundation of the inpatient prospective payment system used by Medicare, and honestly, a ton of commercial payers too. What's really fascinating here is the specific recipe used to assign that DRG. Medical coders aren't just making educated guesses. They feed very specific clinical and demographic data into a software engine known as the DRG grouper. We're talking about key ingredients like the principal diagnosis, secondary diagnoses, major procedures, the patient's age and sex, their discharge disposition, and those critical present on admission or POA indicators. If you change just one of these ingredients, your final payment tier can shift dramatically. It's like a chain reaction. Because of that, getting the very first ingredient right, the principal diagnosis, is an absolute must. But watch out, because there's a huge trap right here. The principal diagnosis is not always the primary reason for admission. Let me explain. The primary reason is just the chief complaint on day one. Let's say severe shortness of breath. But the principal diagnosis, that's the condition established after study to be chiefly responsible for the admission. So if testing proves that the shortness of breath was actually acute respiratory failure, that becomes your principal diagnosis, and that one distinction drives the entire payment category. Right, so once that principal diagnosis is locked in, the DRG grouper sorts the patient into one of exactly 25 major diagnostic categories, or MDCs. Think of these as 25 massive buckets that generally align with major organ systems or disease types. For instance, MDC 04 captures respiratory system diseases, while MDC 05 grabs circulatory system diseases. Every single inpatient claim starts by funneling the patient into one of these 25 buckets. Once the patient lands inside their MDC bucket, the architecture splits. The case gets partitioned into either a surgical group or a medical group. And this split is based strictly on one thing: whether a significant operating room procedure was performed. If a major OR procedure took place, boom, you go down the surgical path. If not, you stay on the medical path. It's only after this initial split that the system even begins to look at severity adjustments. And those severity adjustments are what create this really rigid DRG tier system. You can think of these tiers as financial multipliers. Nearly every MSDRG is broken into 3 payment levels based entirely on secondary diagnoses. At the base, you have without CC/MCC. That means no major secondary issues, so it gets the lowest payment. Step up to the middle with CC, which stands for complication or comorbidity, and the payment increases. At the very top, with MCC, a major complication or comorbidity, yields the highest payment because it clearly demands maximum hospital resources. Let's ground those acronyms with some real clinical examples. What actually qualifies as a CC or an MCC? Well, CCs add moderate severity to a case. We're looking at things like anemia, a UTI, or malnutrition. They definitely require extra nursing care. But MCCs, those are the heavy hitters. They signal intense severity and massive resource use, conditions like sepsis, acute renal failure, or septic shock. Getting the documentation to capture just one MCC can literally double the relative weight of the entire claim. It's that impactful. But listen, there's a pretty big catch here. You can't just slap a severe condition on a chart and automatically rake in higher reimbursement. It all hinges on present on admission, or POA indicators. If a secondary diagnosis, yes, even a massive MCC like a deep vein thrombosis, is coded with a POA indicator of N for not present on admission, it's flagged as a hospital-acquired condition. As a penalty, Medicare often blocks that condition from increasing the DRG weight at all. Basically, you have to prove the patient already had it when they walked through the door. All right, to wrap our heads around the grouper's logic, let's look at its strict 5-step flow. Step 1. Lock down that principal diagnosis to find the base DRG family. Step 2. Comb through all secondary diagnoses to pull in those vital CCs and MCCs. Step 3. Identify any major procedures to drive that surgical or medical split. Step 4. Adjust for demographics, like the patient's age and where they're being discharged to. And finally, Step 5. Assign the MSDRG and calculate the final relative weight. To really see this in action, let's apply it to a highly complex, everyday scenario: sepsis. The sequencing guidelines here are brutal. First, you absolutely have to code the underlying infection, like pneumonia. Then, if the provider actually documents severe sepsis, you add a code for that, which must be followed by a code for the specific severe organ dysfunction, like acute kidney failure. You can't just vaguely code severe sepsis without explicitly linking it to an infection on one end and organ dysfunction on the other. The required specificity is off the charts. Because the required specificity is so intense, hospitals lean heavily on clinical documentation improvement, or CDI teams. Think of CDI as the essential bridge connecting the clinical, conversational language of physicians with the highly rigid, rules-based language of medical coders. CDI specialists are in the charts while the patient is still in a bed, hunting for missing specificity. They make sure the written documentation perfectly matches the clinical reality before the bill ever drops. When a CDI specialist finds a gap in that story, they send a query to the physician. But here's the tricky part. They cannot just tell the doctor what to write. That is a massive compliance violation. Instead, a compliant multiple-choice query sounds like this. Reviewing documentation of sepsis and clinical indicators like elevated lactate, please clarify the patient's current status. Then they offer options: septic shock, severe sepsis, sepsis without organ failure, or other. It gently asks for clarification without leading the provider down a specific path. So, what exactly makes a CDI specialist fire off one of these queries? Mostly, it's about documentation gaps. The biggest trigger is an ambiguous diagnosis. For example, writing history of stroke instead of explicitly saying history of cerebral infarction. Another huge one is missing acuity. Was that respiratory failure acute, chronic, or acute on chronic? Missing cause and effect linkages and missing present on admission statuses are also massive red flags that CDI teams are constantly hunting for. And those queries are an absolute necessity because coders are handcuffed by strict general coding guidelines. Instructions like code also literally mandate that a coder capture both the underlying disease and how it manifests. Code first tells them an underlying etiology has to be sequenced before the manifestation code. And listen, using non-specific codes like not otherwise specified, that's a huge red flag. It makes you a sitting duck for payer audits and almost always drags down your DRG payment. All right, we've talked a ton about diagnoses, but what about the procedure side? Inpatient procedures use the ICD-10 PCS system, and it is a completely different beast. It uses a fascinating, highly structured 7-character alphabetic code where every single character tells part of the story. You literally build it. You start with the section and body system, move to the root operation, say an excision, then you identify the exact body part and the approach. Finally, you note any device left behind and an extra qualifier. Every single inpatient procedure gets built using this exact skeleton. Let's zoom in on just one of those pieces. Character 5, the approach. In the medical and surgical section, there are exactly 7 approaches a physician can use to reach an anatomical site. This ranges from an open approach, literally cutting through the skin, like a full laparotomy, all the way to a percutaneous approach, which is entering by puncture, like a fine needle aspiration. Knowing exactly how the surgeon reached the site is absolutely make or break for building an accurate procedure code. When you bring all of this together, stellar physician documentation, razor-sharp CDI queries, and perfectly constructed CM and PCS coding, you achieve exceptional coding. And at the end of the day, the ultimate goal of the MSDRG system isn't just to squeeze out revenue. It's about capturing a true reflection of your patient's severity of illness, or SOI, and their risk of mortality, or ROM. This pristine data is what drives public quality metrics, benchmarks your hospital, and proves the true complexity of the care your team delivers. Which leaves us with one critical question to wrap up today's explainer. Is your hospital's documentation telling the true story of your patient's severity of illness? Or are vague notes and missed CCs secretly bleeding out your quality scores and your revenue? Really think about that. Thank you so much for joining me today, and remember, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. See you next time.